Hello, everybody, and good evening. Welcome to our main orthopedic review, part two, prep and success webinar, the first in a series over the year. And I wanted to introduce myself. I'm Bruce Gomberg. I'm the co-director of the main orthopedic review, and I'm happy to be here with you tonight. I wanted to give you a little bit of a rundown about our course quickly, and that is if you haven't heard, the main orthopedic review is the longest running independent orthopedic board review in the country. And we've been going, this is our 66th year. We have a very long track record of success, and we're happy to help and are here for board review needs. We give a part one and a part two section every June. And it's in the Boston area at Endicott College, a beautiful oceanfront New England college. It's a great place to get away, but also easy access from Boston. And with that, I'm going to just give a quick introduction to our faculty and panelists tonight. We have Dr. Tiger Li, who's a professor at Boston University Department of Orthopedics. He's a sports medicine surgeon. He's been with MOR for many years. He's my newest co-director. He brings energy and ideas to the course, and he'll be talking a little bit about organizational skills and what he thinks is important for part two board prep. I also have tonight Nate Olszewski. He's at Boston University as well. He is an orthopedic traumatologist and a newly minted board certified orthopedic surgeon. So we get a unique perspective from somebody who's been through this whole process just recently. It's fresh, and he'll give a great perspective from somebody who's just on the other end of the pipeline. And then we also have Dr. Michael Blankstein, who's an assistant professor at the University of Vermont. He's also been with Maine Orthopedic Review for a long time. He's, as you know, the voice of the OTA podcasts, and all around great arthroplasty and trauma surgeon. And with that, I just want to give a quick intro into the oral boards. As you probably know, the oral boards are happening every year around July in Chicago. And the mechanism is that the board collects a 6-month window of your cases. This year, the window was between January 1st and June 30th. And from that board collection period, they'll collect your cases and select 12. And those 12 cases are ones that you will need to prepare for and present to the board and present your thoughts and how you went about treating these patients, including gathering data, making the diagnosis, doing the operation, technical tips on the operation, and follow through. And I'll let the rest of the faculty talk more about that. And without further ado, I'd like to introduce Tiger Li, who's going to give his thoughts for the next few minutes on board prep and organization as well. Tiger, take it away.
I just got a couple slides I prepared for it. So, so if you look at really the key dates, I think everybody knows this. I'm not sure everybody's taking the 2025 or 2026 and trying to get a start up. But December 31st in 2023, you're starting logging patient reported outcomes. And then January 1st to June is when you collect the 6 months of cases, and you can start, putting in the scribe. And then the application starts in January, and then August 15th is the deadline for submission of complete application fees and the scribe 6-month list by 4 p.m. I think there's a deadline, there's a late date for that. You can pay an extra few $100 and do it. But I think if you can get everything in time, that'd be much more beneficial for you. And then August 31st is the last deadline that you can do that. April is when they meet and then credential whether you can actually sit for the exam or not. And then in May 31st, they'll receive your time in a dashboard. And the deadline upload images is in June 2025. where you're recording the slides, and then the case and examiner fee, and then you'll get your case list somewhere before that, and then part two examination occurs in July. It is between 20 and 23rd and 25, and is in Chicago in the Hilton. It's been there for the last, I don't even know how many years. I took it 10 years ago. Nate just took it recently. But I recommend that for everybody who takes a course that you get there a couple days early, not the, not the day before, because in case something happens, you're playing weather, rain. If you don't get there by the time your exam starts, you gotta recollect. They're not gonna give you a leeway. You're not gonna go back and take the exam. They won't give you that delay. So you make sure you get there at least a couple days before. And then the results posted on dashboard on September 1st. I think this year was the first week of September we got it, a little bit later. So there's 12 cases, 2 examiners in one table, 4 blocks of 30 minutes each, 2 hours. Typically 3 cases per block, about 10 minutes per case. That's the way it was for me. It goes by very quickly. You literally go in there, there's 2 examiners. One guy is looking at your notes, and the second person is asking you questions, and then they're kind of checking back and forth what you're saying with the notes and then documentation. There's a little bit of break time, and then it's really important that you kind of focus on the examination, I think, and how you prepare and how you present the case, which Dr. Blankstein is going to talk to you about later on, because I think presentation is probably the most important thing, how you present the case, really more than anything. And then you want to know how you're graded, right? So how do you pass the exam? And we just did a survey of all the people here that took it last year, 34 out of 65, and they all passed. It was a 100% passage rate. I think we have one person that failed it, but they failed for the 3rd time, so it's not really, I think it's their fault more than anything. Um, but how do you pass? So really, every single case that you do, this is a rubric, how they score you. So look at this and just kind of look at what they check off. Data gathering, diagnosis, interpretation skills, treatment plans, surgical indication, technical skills, complications, outcomes, ethics, professionalism, biology. And then they check off, are you above expected level, expected, below, or unexpected? And you can see exactly, and tell you exactly what it is in each category. And then they check off each case where they are, and then there's a score that composites of that, of each case that you do. And then you get a passing score based on those composite scores. I could tell you that you could flunk 2 or 3 cases and you'd be fine. You know, you could still pass exam. It doesn't have, but if you fail like 5 or 6 or half your cases, and that's not good, that's not a good thing. And then ethically, you got to make sure you get the x-rays and everything, images, make sure this, the patient's label right. I think, Shep Horowitz, when I took it 10 years ago, he told us only the people that failed that year, there's a couple of people that failed they right off the bat, was they upload the different post-op images than the pre-op that they did. So they did a knee replacement on somebody, they uploaded a totally different post-op x-ray that looked better. And they caught them. And they failed. 2 people failed because of that my year. So make sure ethically, you just can't do that. And then peer review is important. You got to pick the people that know your practice and pick the people like you. If you don't pick the people that know your practice and don't like you, they can put something in there that doesn't, go your way and they don't like you. They can audit your practice. So they can come back and look at the peer reviews and, one, they could say you're not eligible to sit for the board, so they can come back and audit you because of what people say. And the second thing is if you look at the exam passage rate in the last few years, when I took it, it was 5% failure rate, very low. But the last few years they really up the criteria, and there was a 17% failure rate in 2022, and a 13% failure rate. It's about 10 to 20% failure rate every year. So I think it's really important that you guys prepare for the case, get the documentation right off the bat, and then take a review course or have somebody come in and take a look at your cases, go over with you, and the more you practice, the better you're going to be. That's really important because you can't really do more. You can't keep practicing, presenting, and getting more people feedback on it. That's how you pass these exams, because the failure rate is much higher now in the last 3 years than it was when I took it. It was only 3-4%, 5%. And I think whether it's course or whatever other course you take, but I think the main is really good. But I'm biased, but you do need to take a course or have your case be presented, and somebody really can like pimp you on a course and the cases and get you to think about them. In terms of documentation and imaging, I do sports and shoulder, and I think this applies to most people, but not all. But detailed documentation cases, you gotta have the history, exam the images. you got to document failure and non-operative management. So 90% of what I do is elective surgery. So you got to do at least 3 to 6 months of consider management for the boards. Whether it's injections, physical therapy, anti-inflammatory medications, it's really important that you got to document that failure and non-op management. For trauma, for something that Nate Olszewski does, those are, just totally different. That's trauma. You got to fix the fracture. For what I do, elective cases, non-op management, you got to document exactly what you did for these patients. Complex cases, um, if you haven't seen it, get a second opinion. Have somebody else in your practice look at it, document their notes, what they said, upload those notes, what they said, and then you either go by or don't go by it. But I think it's really good to get a second opinion just to show you that you're thinking about it. You're thinking, getting advice from other people because you're very new in practice. That's really good. And then if you really want to do the case and you don't want to get pulled for the board, be the assist. Have somebody in your practice be the primary surgeon. You come up as assist. You don't get pulled for those cases. That's something you can do to neglect not to have to report them. In terms of key images and notes, upload every note in the office, H&P, op note, post-op notes, PT notes, console, everything you get. I uploaded every single note that I had, and I labeled them based on what the date was. The post-op, whether there's like 2 weeks, 6 weeks, 3 months, 6 months, and then the PT notes. I got everything in there as detailed as I can for these patients. Images, X-rays, MRI, CT results, revision notes. If you did a revision case, make sure you document it really well. The key images, you got to label them well as well. If it's a CT, MRI, if you're doing a labral repair, you got to get the image that shows the labral tear. If you're doing the ACL reconstruction, you got to show the images that show the ACL being out. Or the meniscal root tear, you get a coronal image of the T2 weighted image looking at the back of the root to show them that they have the root tears. Those are really important images. And then if you do scope, for shoulder knee, you got to get the scope in the right pictures. The pre-op, what the pathology shows, and then post-op and what you did and the repair after. The examiner is going to want to see all those images for you. And then any second opinion notes you got to get in there. The most important thing is, you don't fail based on complications. Everybody has complications. Everybody that operates, they do a lot of cases. We all have complications. You fail if you cover your complications, you don't take care of them, you don't send the right person, you really don't take care of them. That's how you fail this exam. So if you have complications, you want to make sure you document the complications, what you did to it. If you get another opinion, you want to make sure you document the notes. And then if you take care of the patient, you brought them up back to the OR, what you did. And also the most important thing is what you learned from them, the complications. Is what you got out of these complications, how you became a better surgeon because of these complications, what you learned and what you're going to do better next time. If you go right off the bat and present it that way, say like you had an ACL, you failed, and you presented it, say, I failed ACL, this is what I learned from it, this is why I failed, and this is the case. And people is going to say, great. I mean, that's a great case because you learn from it. And that's really what, art of medicine is about. And pre-op outcome, post-op outcome, I think you guys have to conduct those. So I didn't have to do that when I took my boards, but I think the AAOS do send the post-op. I think they can comment on that more when he talks about it. But when I did it, I did do a pre-op outcome scores for shoulder and knee, and I had a 6 months or a 1 year post-op outcome scores. I just did it quickly, like either IKDC for the knee, and then I did an ASCS and this same score for the shoulder. So something simple that you can just document that how the patient did. And then in terms of follow-up post-surgery, you should have a 2-week note, 6-week note, 3 months, 6 months, 1 year. Do not have your PA see the patients during this time for 2 weeks. My PA sees on my post-op patients now, but when I took this board collection, don't have your PA see the patients. You see the patient at 2 weeks, 6 weeks, 3 months, 6 months, 1 year. You documented what the progression is. It's about, like how detailed you are with the patients and how you manage these patients. That's really important on you guys being successful on taking the exam and passing. So really with that, those are some of the tips and tricks that, I thought was important, and I'll give it up to the next person, Bruce.
Thanks, Tiger. I appreciate it. Michael Blankstein, I'd like you to chime in a little bit. You have a few minutes on what's the preferred way to organize and how you would do it.
Thank you. My internet connection is a little bit funny, so excuse me if it slows down for a second, but overall it's pretty good. So Yeah, Tiger, that was awesome. And I don't have an actual presentation. I'm just going to give you my thoughts. So the way I see this exam is this. This is actually the fairest exam of your life if you come prepared, right? These are this is an open book test and you're actually writing the book, right? You are actually the author. You're the one who's creating the story. The examiners do not actually review your cases beforehand. They're actually reviewing them live on the spot when you're presenting it. So in the end of the day, one of the most important things to be organized with you is the practice. Um, I think the most important thing to do is to practice presenting the cases multiple times to multiple people from different divisions. So if you just present, for example, to the arthroplasty guys and the arthroplasty guy, they may not ask you an interesting question that, for example, the trauma guys would. So I actually reviewed my cases with multiple partners, even my spine partner, my sports guys, trauma guys, foot and ankle guys. If there was anything that's relevant to them, they always ask really interesting questions, and by doing that you try to see what your deficits are in the story. This is why a review course is amazing, because you actually get to practice it, and you get to show every single case, and on top of it you see how other people are presenting it. So the organization, the way you tell the story, is probably the most important thing of this entire process, of course, assuming you've done safe surgery and you documented everything. So there's like the prep work, which is what Tiger talked about, and the actual clinical practice. But then there's the presentation. And you see people are disorganized, often lose the examiners, right? So for example, if I'm hearing about somebody's got bad knee osteoarthritis and I'm starting to talk about knee replacement and I still haven't seen the x-ray, I'm just like thinking, okay, what is this guy doing? Whereas if somebody has a really bad or badly arthritic knee, the first thing you want to do is show the x-ray of the knee, and then you start telling the story. I think what you need to do is to really let the story follow the really, or the grading refs follow the story. So for example, if you say, well, I fixed a hip fracture and intraoperatively I made sure that I was happy with my guide wire position and my tip apex distance, then guess what? If you're able to show that as you are doing the case, as you are presenting it, then it just makes the story much more palatable for the examiner, and they're with you. They're following the rationale. Um, they are engaged. What you don't want to do is show them the pre-op x-rays, talk about what he did, and then when you're done talking about what he did, suddenly show them the the intraoperative x-ray. So the keys when you're doing the history, show the pre-op. The intraop, show the x-rays, etc. So I think that's like one of the biggest thing that I can tell you. And on top of it, you will never be able to do that until you practice. You see, we're used to doing exams by studying independently. You know, many of us do study. You're used to studying in the library or maybe small discussion groups. But this specific exam is based on your own presentation. So the only way you can get better at it is by practicing the presentation. And as you do it, you realize, you know what, I probably don't need as much detail here. Maybe I need more detail here. And again, I cannot stress how important it is to have the story told in a chronological way where the images follow the story. Okay, now we get into the most important thing, what stresses everybody, which is how do you present your worst complication? And this is what Tiger touched on earlier, but I just want to talk about this a little bit more. So we're all worried we're going to fail because we had a complication. And that's actually not why people fail. The reason people fail is because they didn't do the right thing. And if they didn't do the right thing, so for example, if you have a complication and you didn't see the patient afterwards, yeah, that's a bad problem. But if you saw the patients and you sought additional opinions and you tried to take care of that patient, even if something bad happened, you're still going to get the credit for being a thoughtful physician. So, for example, if somebody gets a blood clot post-operatively and it turns out that they were not given the appropriate DVT prophylaxis. So what you can do is say, well, this is what happened. This is how I dealt with it. I went to the patient. I ended up consulting hematology. I ended up making sure that this is never going to happen again. One of the things you can do is you can say, you know what, I instituted a program. Well, this is never going to happen again. So now we have these standardized pathways to make sure that this is never going to happen. People are going to appreciate it. What you don't want to do is lie about it or say, I ordered the aspirin and it was never given, etc. So although the focus of the complication is where we're all thinking, oh my God, I'm going to fail this exam. If you show that you dealt with it like a doctor who have a way to proceed forward to make sure it doesn't happen again, and you consult a colleague, you get other people involved, then I think you're going to be fine. Whatever you do, you don't want to lie, and you definitely want to highlight that you are there for the safety of the patient. That's really what they want to figure out. They want to see that you're organized, you're able to tell the story, that you're able to take care of patients, and you do it in a safe way. I think I'll stop there and we'll continue the discussion afterwards.
Thanks, Michael. Yeah, I think you hit upon some great points. I do want to stress, as everybody else did, that coming across as a safe and ethical surgeon is probably your primary goal in taking this exam. I would like to put a question out to the panelists about second opinion notes and consultant notes. What do you think is important to have? What kinds of things would make your story roll a little better? And for instance, complicated arthroplasty patients may have consultant notes from medical consultants and maybe even the anesthesiology team or other subspecialists. So can you talk a little bit about that?
Yeah, I can start. So for the trauma stuff, we had a lot of inpatients, like with consults with the tax team, neurosurgery, different things. They want, at least in the ABOS website, it says upload consult notes there. So I uploaded it, and with my things, it was always just making sure we had like a clear communication plan and that the things were discussed, like their head injuries, their chest injuries. And I even would have that like documented in my progress notes or my note going into surgery that, I've discussed the case with X, Y, and Z regarding the patient. We've deemed that this is an optimized situation for it. And, talking to my colleagues that have done joints, they want you thinking about and identifying the medical problems and working them up before you jump to surgery. And so they want those notes uploaded to show that you've thought about it. Because you are going to have sick patients or with medical comorbidities, and they want you to know that you're thinking about it and addressing it. From my experience, is my 2 cents on that situation.
Great, thanks, Nate. I agree with you. I think not only do you have to have those notes available, you need to know what's in the notes, and if there are specific conditions or medicines or protocols that apply to your patient, it's really good to know a little bit about that. You don't, for instance, need to know how to treat Wolff-Parkinson-White syndrome, but you should know a little bit about it if your patient has it. Or if your patient has a kidney issue, you should know what's in the nephrology note, not just have it uploaded, but really know what's in there and what the nephrologist recommended. I think it's really important to be complete and know everything you can about that particular patient.
Yeah, exactly. It's the same thing where we keep on saying the same message, but it's just amazing to see how important it is. You have 12 cases, you need to know everything about these patients, and you have to tell the story as if it's not the first time you've told it. The practice here makes probably the biggest difference. So exactly, if you highlight the nephrology consult, then you can say, I consulted nephrology, this was their recommendation. Boom. Then I consulted cardiology. This was the recommendation. They wanted me to order a CAT scan. This is what the CAT scan shows. Just tell the story in a way that makes sense.
Great, great.
Yeah, and also I just follow up with that is that you got to be confident in what you guys are saying to the examiners, because they can read the note, but they don't have that much time to go through the details of the note. But if you're wishy-washy about your response, they're gonna pick up on it. But if you're gonna say this is what they did, a lot of times they're gonna skim through it. They're not gonna, go through it in 100% details. But you gotta be 100% confident in what you say. You gotta know the patients. You gotta know what the recommendations are, what you did. And then you got to be able to present the cases with a lot of confidence when you do these examiners, because a lot of times they're relying on reading your notes, and there's a lot of notes, a lot of details in there. They can't get through all that stuff. But if you're, wishy-washy and you're not confident about it, they can pick up on that, you know.
Yeah, good point. Good point. Let's before we go to Nate, I just want to address the one question that came up in the Q&A, and that was for sports cases, do you get to pick the patient-reported outcomes that you want to use, or are they prescribed? And I'm going to ask Nate to answer that, just because when I was going through it, nobody even thought about outcomes.
Yeah. So I didn't do like sports and stuff, so I don't have any specific outcomes that they asked for, but I think what they use now is the email for it. So you like all your elective cases, you need to get the email from the patients and upload it right away. The trauma setting is a little different because they're coming in, things are moving quickly and stuff like that. But for sports, total joints, the things that are booked electively, they're going to ask you to upload the patient's email. The patient can opt out, but they expect you to upload them. And then they use that as like patient reported outcome measures. And I don't know how they're using it yet. And I think it's still kind of growing, but I would basically echoing what Tiger said is pick one that you know and consistently use it and make sure that you're measuring off of it. So if there's like a standard for rotator cuff repairs, use that. If there's something for total joints, use that one, and know the components and have it ready, because they want to know those things and kind of gauge that you're tracking your success rates and your complications and how you can get better.
Great. Thanks, Nate. So Nate, why don't you take it from here? I'll give you the floor and introduce Dr. Olszewski. He is at Boston University, a traumatologist who's recently gone through the process, and I think he gives a really unique perspective on what it was like and what it's like to be on the other side of it.
Yeah, and just to echo what Tiger said, the travel thing is real. I'll give you a personal story. We were flying out 3 days early. Our flight was broken. The plane bringing the part in was canceled, so our flight got canceled. So we had to book a new flight and pay money. In all seriousness, like I would book a flight 2 or 3 days early, and then the next day book a refundable flight so you have it already, and then just cancel it if need be, because it's going to be way cheaper than trying to find it the day of. Like, this is a test you can't mess around with. It's one day of your life and you have to be there. So that's my travel thing, is to get out 2 or 3 days early and have 2 flights booked, because travel's chaotic nowadays, especially with the whole crowdsourcing that happens. So all right, I'll pull the slides up for this. So thanks for having me on, Bruce. Appreciate you letting me share my 2 cents. Hopefully I can help, a couple people with this, but general tips is this whole process takes time. Set aside the time to do these tasks. All of the tasks need to be completed and they need to be done early, especially your scribe list. One of the girls that was applying in my year got her certification list in 15 minutes late on the second deadline, and they told her no, and she has to redo her whole collection thing again. So they're serious about the deadline. So don't miss them. Don't mess around with them. Make sure, like I said, follow the dates, and then keep up with logging on a regular basis, or stay organized. For me, I just stayed organized, and because I submitted everything at the end, but they are checking the patient reported outcomes with emails. So the earlier you send it, they'll start actually sending out emails and start collecting the patient recorded data. Make boards collection part of your practice and your workflow. So in order to get the email, they want you to have a consent that they sign for, in case there's any healthcare violations. Like I talked to all my patients that I got it and said, hey, this is going to be coming. I'm in my board's review. This is what it means. This is what the process is. And you might get an email asking you to answer some questions. If you can do that, it'd be greatly appreciated. Again, the consent forms were just part of my clinic flow. So whenever I booked someone for a case, I had my surgical consent and I had the consent for the email and the board's collection stuff. And then I put all my thoughts and ideas and my thought process into an indications or my progress notes and my op notes. I had it documented everywhere. This way, if it ever came up, you're going to go back and you're going to review these cases and you're going to do a decent amount. You're going to be like, oh, what was I thinking on this one? Was it this or that? If you do it up front, you don't have to think about it again. You just know it and it's there for you to just hammer in. Document a physical exam on everyone, write a note on every patient pre-op. There's a couple reviewers particularly that I've heard will look at only your documentation and grill you on that. So, if you have a PA who's seeing your patients, make sure you actually write your own note, write your own exam in the pre-op area or in the clinic. I would just say don't have a PA or do anything during your board's collection. It'll just eliminate that. But I know every practice is different. Don't try and hide your complications. Oh, and then that's been mentioned multiple times. I had a bunch of complications and there were some really bad ones. I still passed because I, knew what they were, how to address them, and what I would do differently to prevent it in the future. Follow the instructions and timelines on the ABOS website. That's huge. Everything's laid out there for you. Stick to it and then keep moving along with it. The ABOS website has a lot of the stuff on it for you guys that you need to do. Organizing your cases. Early organization helped with me for uploading my cases. I'll show you. I kept an Excel sheet that was required, all the information I had to go into the scribe part. I collected the emails on there, got the consent forms, like I said. The elective cases, they really want you to try. If you go with no emails, I think that's kind of a red flag to them because they do use that data in some capacity. So they want to see that some of it's there. You can't force your patients to do it, but if you do enough cases and enough people, they will do it. You'll see your patients are willing to help you, especially if you explain to them what the whole process is and how it's going. And this is just an example of my running Excel sheet. I still do this today. Every case I do, I put in the date, the MRN, their initials, their age, what their gender is, and the ICD-10 codes. I use Epic. So when I do my case, I just go to the diagnosis, and when I'm doing my op note, put that in and it pulls up the ICD-10 code. And if you have those, your data entry is going to be way easier than trying to search in their thing, which is not a user-friendly thing. So if you have the ICD-10 codes up front, you're going to see the scribe list will be way easier to do than if you don't. And then, just my CPT codes there. And then what I don't have on the right of it, because it just got too small, was emails. And then as I was going through, I was trying to keep a running tally of, if I knew a patient had a bad complication or what their last follow-up was and just how things were kind of progressing, just so when you go through and you enter the data, you have it all in one spot. You're not trying to go through the chart and do everything and look through every note to figure out what was going on with the patient. So I basically took, I think, 2 Tuesday, Wednesdays off because my schedule allowed for it. I just blocked it off, and a couple weekends there too, and just uploaded everything into Scribe, and I got it done a few weeks ahead of time. I did all my work at the office so I could log into the EMR, review what I needed to review, and enter the data. It was just easier to do it there, but I also know being at the office, people would walk by and say, hey, can you help me with this or that? So it's a balance. And like I said, get the case list uploaded as soon as possible. Don't wait till the last minute, because you might come to find out that your medical review people take 4 weeks to review your case list. So start asking for the contact information of the people in medical records that needs to verify your scribe list, and see how long it's going to take, see what their deadline would be, and give them a heads up that it's going to be coming so that they know to do it, and that what kind of deadline you're running on. Because if you're working on the ABOS deadline and you get it done a week ahead, but it's going to take them 3 to 4 weeks to review, you're done. You're not going to be able to take your boards that you're going to have to wait. And like I said, I know one person who that actually happened to, and 15 minutes late, they told her no. She even tried to ask and they said absolutely not. So they don't mess around with it. You're also going to need different things. Again, this is all right off the ABOS website. Chief of staff, chief of surgery, your chief of orthopedics. You're going to need their emails. They'll send out peer reviews to make sure that ask them some questions and just fill that out as a character type thing. You'll need partner email addresses and 5 surrounding orthopedic surgeons. In Boston, it's easy, but if you're in a smaller community setting, there's not a lot of people around. You'll have to find other orthopedic surgeons that you can reach out to, or that you refer patients to, or refer them into you to get it. Again, it's for character review stuff from the boards. You're also going to need documentation with hospital privileges. This is not your letter that you signed when you started. It's an actual letter going back to when you started and where you currently are, and that you're in good standing. A copy of your medical license. Again, this is all on the ABOS website. It's all there. Look it up, get it organized, get it into a folder, and just keep it there. So when you come time to do it, and I don't know if people have done the scribe list or not already, but for the newer ones that will be coming up, this is, what I did to really help me kind of work through it. And I didn't have any issues, or I didn't stress out too much. Getting the images that you need. Tiger talked about this a little bit. You have to figure out how your PAC system can download images and where they go and what size quality they are. And the newer computers, you can screenshot, it's a high enough quality, but we have Sectra, so we can download with de-identification. So maybe there's a way to download in your PAC system that you can click a button and it de-identifies and just lets you save. And then, make sure it's within the size of the files and that it's not uploading small or anything like that with it. I can't stress this enough. Just follow the instructions, get everything done on time, and you'll be fine, and that will remove that variable. You're going to need HMPs, consents. Make sure you write out your own consents, or if you have like residents that do it, you sign it, addend it as you need to adjust for it. That's a big thing that they want to see, is that you're doing your own consents. You're not just going in with consents that aren't signed. See your patients, like Tiger said, don't have a PACM 2 weeks. When you see your patients and you have to write a note, you've done your documentation and you'll have it for uploading everything that you need in the process with it. And for when you go to take your boards, write your own progress notes. One of the people that I know that failed used a scribe, and that was part of the issue. It sounded like they don't tell you why you fail. We have to guess why people fail, but documentation and not knowing what's going on with your patients is one of the main reasons. The labeling of your images and notes, they'll tell you how to label it. The most important thing is the end of the file. The underscore and then the date is the most important thing you want to do, because that's when you upload it into the system, it'll then organize it based on that. Their algorithm uses the last code there of the date to organize your notes in order. So you'll see when you go use the drop or the drag and drop uploading system, not their list one. And if you do that, you'll see where you can drop stuff into, and you can bulk drop things in, and it'll auto organize your notes based on the dates. And you'll see the system, when you log in. I don't have access to it anymore, and I don't have any screenshots of it. I should have done that for you guys, but I didn't know I was going to be doing this. But you'll see where you can drop it in. And if you have everything organized, like case 5 in a folder, progress notes, post-op day 1 from the inpatient side for the trauma things, is what I had a lot of those. 3 months, 2 months, it just makes it easier to find and organize, and right where everything needs to go. And at the end, then it'll print out your EMR, they call it, and you'll see what you can run through at the end. So general tips: stay organized, set time aside, get your things done as soon as possible, especially the case list and the scribe list. Make sure you know when you need to get it done for medical records to review it. See your own patients, write your own notes, have regular follow-up. So I know Tiger said like 6 months and then a year. Our clinic doesn't book more than 3 months at a time. So I would just see people at 3-month intervals and just keep bringing them back to make sure I had the follow-up. It doesn't mean, for me, for trauma, people come and go. They might be from out of town. That's okay. But they want to know then that you've, had a phone call, or that you have a plan for them to follow up, that they're going to an orthopedic place, that they have your number, that you've tried to give them somewhere to go, like that. Those are things you have to do to help with that, and just follow the instructions. I would do all your own imaging gathering, your document gathering, and your de-identifying. I, asked someone to de-identify for me, and they missed a bunch of stuff. So it was actually more time cumbersome having that, because I was trying to figure out what they missed versus just doing it all myself and knowing where it all went. Invest in a PDF editor for a couple months, and it's pretty quick once you get in the flow of it. Embrace your complications. Know what it is, know what happened, what potentially went wrong, what you're going to do to address it going forward. Practice your cases. The more and more you practice, the better your storytelling becomes, the more confident you are. And you're also using the system that you're going to use the day of. So you know how to go through your images and everything. And then, just know some of the basic literature. It's not there to grill you on like what's the newest literature that comes out, but if you know what the newest literature or what you use to make your decision, that's going to help you during the process too, because they'll ask you a question, oh, is there literature to support that decision, or what made you do this? And if you can reference that, and it'll just make it go smoother for you. And that is all I have for now.
Great, thanks, Nate. I appreciate it. Let me just follow up with a couple of questions for you, Nate. One of the things that's been asked before is, how do you deal with images and notes that you have to possibly get from multiple hospital systems? Did you have a way of doing that? Did you dedicate some personnel to do that? How'd you do that?
So luckily for me, I'm just at one system, but I did all my own data gathering. But you can, you'd have to call the hospital and have them send over stuff to you. There's a way they can send files, so you can do that. Like I know people that called outside hospitals for patient follow-up, and they sent them the images, even screenshots on their phone, and just uploaded it. So if you're not at a system and you're just trying to get follow-up from somewhere, you can, show that just taking the time to show that effort, it's going to reflect that you care about what's going on. If you work at multiple centers and you need to get the imaging, you're just going to have to make sure you have the access. And like I said, I would probably just put it on yourself, because if you want to know it's done right and you have what you need, it's probably safest to just do it yourself. I know that's why I said, like, if you can, schedule some time off to dedicate to this, right? This is the one test you have to pass in your life to keep going and do what you want to do. So don't mess around with it.
Great, thanks. Yeah, I think everybody hit on some of the highlights. One of the important ones seems to be complications. The board these are experts in picking your worst possible cases. Everybody has complications on their list, and everybody prays that they don't get picked, but it's very rare to have a case list that doesn't have complications. So they're really good at picking your complications, and I think that everybody addressed that pretty well tonight, showing that, the only orthopedic surgeons that don't have complications are the ones that aren't operating. And so if you have complications that are picked, and you will, it's really important to know what happened, to own it, and to show that you did the right thing to manage it, and that you have done things to hopefully rectify the situation moving forward, so that if you can prevent that from ever happening again. So it's not really something to worry about. They want to know what your thought process is. They want to know that you're thoughtful, coherent, cogent, and, like I said before, safe and ethical. So I do appreciate that. I want to just tell everybody again, we are some of the faculty of the Maine Orthopedic Review. There's 45 of us that get together every summer and go through cases for you. It's really the only place where everybody can share all of their cases, all the selected cases, go through with multiple people like the ones here tonight, and more. We have, we pride ourselves on having very academic orthopedic educators who are accessible and help to optimize everybody's cases. And I think that once you have all the data and you're organized, uh, like Michael Blankstein said, the biggest thing is learning how to tell the story. I think that many people get bogged down with the inability to just move from topic to topic as though they're presenting a patient like an intern, but that's what you need to do. And I really think that people who go through their cases many times in front of many people and know the case inside and out, know about the particular patient, the surgical choices you made, the implant choices you made, the anatomy of what's going on, and knowing about your patient's follow-up are key to this. And like Tiger Lee said, look at the scoring rubric. That's super important when you look at the ABOS site to see how they're going to look at each one of your cases and make sure that you are doing what will garner you the most points. Anything else from our panelists? Anybody have any closing notes? Anybody have one or two top tips for going into this exam or organizing yourself prior to the exam?
Well, I mean, I'm just gonna say that Nate takes care of all the complex fracture here. Paul Ternetta actually refer all the complex stuff to him now. He's a superstar. He does a great job for us, and he's seen a lot of crazy complex stuff here for us. He operates all night, and he's got really good tips for you guys to help you to, pass the boards. And I think the really important thing is just presenting the case to people, whether it's doing a main review course, you're doing it with your faculty, you're doing it with partners. You got to present these cases to people so that they can give you ideas on how to present and ideas like how you can respond to questions. And then if you have a complication, present those complications to your senior partners, your partners to go to our review board, or you want to go another review course, that's totally fine, whatever you want to do. But having other people think about it and then like, present it and then give you ideas how you can learn from these complications, how you take care of it, how you can just even tell examiners what you thought you could have done and what the ideas, and just getting different opinions about it, I think it can really help you pass exam. Because for example, I had a guy that was like literally in the record course that had an ACL complication. He did a mismatch at BTV graft. The bone plug stuck out in the tibia and it was out by 2 centimeters. And the guy was literally closed it up and it was still sticking out. He went back, took it out, revised it. And then I asked him, and the question is like, how did you learn from the case and what did you learn from it? How would you prevent this from happening? And he had no idea. This is one of the guys that took it 2 years ago. Had no idea how to prevent mismatch. Whether, you dial the tibial guide down to be a higher angle, whether you twist the graft 5 times, you can trough it, you can put a stables, you can cut the bone graft down, make it a biocomposite screw, make it a soft tissue graft. But he had no idea how he would improve this and like address it. And I told him all the stuff that you could tell. You could tell this, this is all the ideas that, you could have done to basically prevent the mismatch. And that's the things that I think the examiner is looking at. It's like, how did you learn from the things that happened to you, complications, and what would you do differently to be a better surgeon? That's all it really is. And nobody's gonna fail you if you have 2 or 3 or 4 complications, where you have 5 or 6. But if you have no idea what those complications were and how you learn from it, how you can improve, then that's the people, that's where they're gonna fail you. It's
Tiger, I
when
think,
don't
yeah,
learn
I
from.
think, I think what you're saying is they want to know your thought process.
That's exactly.
Yeah.
That's 100%. If you volunteer information, you gotta know what you're talking about. So I said I put patients on aspirin post-op, and my examiner asked me, how does aspirin work? I told him I did a near, like Hawkins test or whatever, near Hawkins test, Job's test, or Billy press test, and he asked me, how do you do that? What does that mean? To you. So whatever information you volunteer in your presentation, they can ask you that question and they can go deeper to pick on your brain at what you're saying. So if you're saying something, if you have no idea what you do an exam, you have no idea what the exam means or what how you do it, that's a bad sign. So if you say something, you're gonna volunteer that information, you got to know exactly what you're saying and what that means. And also is also, why did you do the next step of the case? Like, why did you take the patient to the MRI? Why did you get the X-ray? Why did you do this, what you done in the surgery? Now, what's your reason behind what you did? Because that's really important. Like, you don't want to do things randomly. You want to do certain things. You want to say it, and how your thought process. What is the reasoning behind the decision making you did for that patient? They just want to know that you're doing, safe job, being a safe surgeon and doing the right thing and trying to be a better surgeon and learn from your complications. That's all it is.
We do have another question in the box about how much time you should take to tell the story for each case. Nate, can you tell us about how much time or the pace of how each case went for you?
Yeah, they say you should be able to get through like the whole story, as complex or not, in about 3 minutes or so. To kind of give the clear picture of how it goes and what it comes in with and the complications and get to it. Otherwise, if you just start rambling and like you're not talking about the important things, they'll start interrupting you. And then that can throw you off of your flow of what you've been doing. Like they'll get to it, be like, okay, like, all right, go to the 6-month post-ops. All right, what's this? Like, why was your reduction here? Like, what did you do with it? Or, they can start, and then you say something and like Tiger said, that opens up an avenue for them to start digging deeper with it. So, you wanted to be able to get out the whole story in about 2 to 3 minutes and then, go from there. They're good about kind of moving you along and keeping you on pace. And they would like come in and say, okay, we have 3 cases to review because it's 12 and there's 4 groups. So you do 3 cases at a time. And they'll say which one of these is, a bigger case and spend more time there. But you want to just be able to boil this down to like a 2 to 3 minute presentation to get through the whole thing, and then it'll kind of fill the thing from there. Luckily for me, I didn't have any issues with documentation or anything that they asked me about or grilled me on, but a lot of my people that went through it before, the year before, in my year, were getting hit and grilled on it. If you have a lost consent, that's okay. Just know it's lost and that, it got lost in the EMR. You can get someone to write you a note saying that there was a technical difficulty and you can upload that. So there's ways to get around it, but it's just knowing that if there is an issue, complication patient or with your documentation stuff, what it was and what you do to improve it. It's like one of my former residents that I worked with, he went and took the boards and he didn't have an exam for the H&P because his PA wrote it and he didn't co-sign it and write his own. And they asked him, well, did you not examine the patient? He said, no, I did. And he said, but, I learned from this. I'm, every time now I write my own note and I have it in all of my things going forward. And he passed, he didn't fail. So that, you can have mistakes and errors. It's okay, but learn from them and know that they've occurred.
Yeah, and I agree. Again, I just want to go back to the telling the story. Exactly. If you have 3 minutes, and I agree, that's roughly a good amount of time. Again, you own the story, right? So if there's something, for example, you're not super sure about, if you tell the story well, there's a chance you might be able to just completely skip over something that you're not interested in talking about because you were able to keep them engaged in following the story. And certain things that you just, not that you should be able to be honest about everything, but there's a chance they may not even focus on the one thing that you're so concerned about. So again, it all comes down to the practice. And if it takes you 6 and 7 minutes and you're disorganized, then you have no time for questions and they get upset about that. If you're done in a minute and you don't have anything else to contribute, now it leaves 9 minutes to go over, a lot of questions. So, it's, again, that's where the practice comes in. That's why the practice is so important.
Bruce, you want me to address that question in the chat about the failure rate or?
Sure. I actually typed one back, but if you can do it in 2 minutes, that would be great.
Yeah, it'll be quick. So, I, heard that it was a lack of documentation and exams. Was the spine that kind of drove it. I guess there was a very high failure rate in spine, and it was people who weren't documenting full neuro exams, things like that. So it's not just limited to that, but it was, you know, documentation, making sure you're doing the right exam stuff beforehand. And they're cracking down on that. And I think that's where a lot of people had issues with it. And that's kind of what I've heard through the grapevine. It wasn't that, you know, people had more complications or anything, but it was a lack of knowing what exam findings meant, what, not doing an exam, not documenting an exam, and different things like that. So that's what I heard the failure rate went up from, partly.
Yeah, I think also, you know, anything that we can put forth is really speculation, because the board is very, very closed mouth about what that's about and why people fail. You know, the people that have failed and called the board and tried to get some information really don't get a whole lot of information about specifics on why they fail. But you know, that's
Right. Yeah. It's is part of the frustrating part is if you do fail, no one tells you why. So you're left guessing as to what you can do better. So, you know,
so don't
and
fail.
I don't know if they've reported this year's pass rate yet or not. I don't know what it
haven't-
is.
I haven't seen one yet.
Yeah.
But we're going to have to wind down a little bit. I just wanted to thank all the panelists. Nate, I really appreciate your time and look forward to having you on board. Michael, as always, coming from Blankstein Tower in Burlington. I appreciate your time and efforts. And Tiger, of course, all your energy and thoughts and ideas about how to make our course better. I just really appreciate you being part of this. If anybody else has any questions, now's the time to put them in the question box or chat box. If not, I hope to see you all in June. You can register anytime. There's no financial commitment till May or so you know what you're getting into. But like I said, there's 45 of us that get together around Boston every year. We're happy to help you get optimized and pass this exam. So with that, I don't see any more questions, so I'm going to end the webinar. And again, send my gratitude and thanks to everybody involved here, and thanks for the people that attended.
Thanks, Mike.
Bye, everyone. That
Appreciate it.
was great.
Thanks.